As we go into the dental abscess case, today's presentation of mine would cover some of tooth morphology, just to identify tooth structure in terms of how we identify them, nomenclature, their eruption sequence, and I'll also touch base with some of the microanatomy and basic principles of oral radiology, which is going to be one of the main diagnostic tools looking into a dental abscess case, and an overview of dental caries, just to understand how the dental caries can get to the dental abscess stage. And it's all preliminary information of you to understand some basic structures to follow the lingo of the articles. This is my contact information. My background is general dentistry. I'm in the division of general dentistry in the School of Dental Medicine, and feel free to contact me with any further questions or related articles. I'll be happy to communicate for additional information as needed. That said, we'll start with the first portion of the presentation, where I'm going to be talking a little bit about anatomy and nomenclature of the teeth. So if you look at any dentition, we have basically two sets of dentition. We have a primary dentition and a permanent dentition, and there are certain age of a patient or a person where you have dentition which has both primary and permanent dentition, and that's called a mixed dentition phase. So the most accepted numbering system of the teeth we use the universal numbering system, where we start numbering the permanent dentition from 1 to 32. That said, there are 32 teeth. And when we look into primary dentition, there are 20 teeth, and we number them by alphabets. So that's the most isolating identification of the numbering system, which is accepted universally. Then this is what you're going to see is, in general, this is a display of a permanent dentition. The areas which are darkened or highlighted are more of a posterior teeth, and the one which are areas which are lightened they are all the anterior teeth. That's kind of a broad classification. I'll go in detail about each of these and specifically what they do. So if you look at a permanent dentition, we have incisor teeth and canine teeth. So between that, they form about 6 teeth on the top and 6 teeth on the bottom, and they are called the anterior teeth. And as you go from premolar to molars, we have two sets of premolars. We have 2 premolars on each side of the arch, and we have 3 molars to the back. And these canine to canine teeth, they all function as anterior teeth, mainly because they are classified based on their function. They are used for incising or cutting the food. But as you segue into the posterior teeth, where you have the premolars and the molars, they are used for chewing or mastication. So as we understand, the first part of our of the digestion process starts in the oral cavity, and they facilitate, all these teeth facilitate to break down the teeth and grind the teeth to better, that is where your initial digestive process starts, if you look into that. So looking at this eruption sequence, it's very important that we understand the eruption sequence of the dentition. So you would know when a patient presents to you what dentition is present and where the pathology is coming from. It's good to identify that. So if you look at primary dentition, the slide on the far left, your first teeth of your primary dentition erupts about 6 to 8 months of age. You start off with your lower teeth, which is your central incisors, and the last teeth to come in are your second molars, which can erupt as late as 33 months, and that's when you will have a full set of primary teeth. And your primary teeth dentition will be there until about 6 years, and that's when your permanent teeth start to come. So it's always good to know this eruption sequence of your permanent teeth as well. That's the slide to your far right, where you would see the eruption sequence of your permanent teeth. And Again, your first molars are the first ones to erupt on the permanent dentition, and obviously the third molars are the last ones to erupt in your permanent dentition, and everything else, the slide represents the age on each of them. So the idea behind this is, if you look at any of the eruption sequence and at a given age, it's good to know where and how these teeth are erupting and what to identify in the cavity, in the oral cavity, when somebody presents to you with that. So again, understanding your teeth structure, as I was briefly mentioning previously, that each teeth have a different function, but then their teeth are also identified by different surfaces. So if you look at the teeth which are close, facing towards the cheek, and these are called either a labial or buccal surfaces. All the anterior teeth till the canine which face the cheek or the lip would be your labial surface, and from premolar to molar they are called the buccal surface, which are touching the teeth. And looking at the inside portion of the teeth, the tooth surface facing either the tongue or the palate are called either the lingual or the palate for the maxillary teeth. And these are your buccal and lingual surfaces of the teeth. Besides that, your chewing surfaces are cutting surfaces. The anterior teeth are, we have the incisal edge, which are to the top of the incisal chewing surfaces, and your chewing surfaces of your posterior teeth are called your occlusal surface of the teeth. And teeth also touch each other. The areas which are touching each other, which are called the proximal surfaces, and we keep the midline as the reference of the teeth, and anything towards the midline is called the mesial proximal surface, and anything away from the midline is called the distal proximal surfaces, and those are the sides distal are away from the midline. I want to spend a little more time on this slide here on talking about tissues of the tooth. There are different areas of the tooth which I want to point out. It's good for an understanding of layers of the teeth which are present. The first one being the enamel, which is the outermost covering of the tooth, and it's by far the hardest material. It's harder than bone as well. If you look at the chemistry of the enamel, it has more than 98% of the mineral content, and roughly about 2 to 3% of inorganic content, organic content in them. On the contrary, the next layer is the dentin. Dentin is a very unique structure by itself. Even though dentin is a mineralized structure of the tooth structure, it has a very dynamic microanatomy to it. The most important thing about dentin is each dentin has dentinal tubules, which allow the end of the odontoblastic process. As you look into the histology of the teeth, which I have given the references for you as a part of the reading for this, you would understand that dentin has about 60 to 65% of inorganic content. So it's drastically a lot less compared to enamel in terms of the mineral content. The most dynamic feature of it is it has the odontoblastic process, which are harbored in the dentinal tubules. So this brings a lot of dynamics into dentin. The most important thing which I would want to bring about is the permeability of dentin. So in general, when your seal of the tooth is broken, which is your enamel, you'll have direct permeability with dentin, because these have they have a lot of open areas in dentin which can access into the further layers of the tooth. So this enamel and dentin you would see only to the crown portion of the teeth. So what I mean by that is the tooth is obviously have two layers in them, two portions in them. One is your crown and one is your root. But for the crown portion is one which you can see in the mouth, but the root portion is not seen. And the root portion is the one which is covered by cementum. Cementum, which covers the root of the tooth, has a very similar structure to that of the bone, but again, it's relatively lot softer than when compared to enamel. And this protects the root of the tooth. And there are other important areas in terms of what they are called. We also have enamel cementum junction. This is where your enamel and cementum meets, and this is where your that's what is called a CEJ. You would hear that throughout the presentation, that a CEJ, which is kind of an important landmark. And inside the dentin and the cementum lies your pulp, which harbors your blood vessels and nerves with all the innervation. And tooth is again suspended in the bone, and this bone is supported by another soft tissue, which is the periodontal ligament, which helps support the teeth and function and help aid in mastication and chewing. So the other portion of the tooth are the other portion of the soft tissue are your gingiva, which cover the bone, and gingiva is the portion where you can see them clinically, and they all have significant importance in providing support, contour, and function to the tooth. So looking into the deeper layers of the tooth, you have the pulp, which is the vital, which harbors the vital tissue of the tooth, which is consisting of blood vessels, nerves, and connective tissue. The pulp chamber is the portion where which opens to the area of the center of the tooth, which is present in the crown area. As I was previously mentioning, you have the crown and the root area, and the pulp canal is the area of the pulp which opens to the root, which is in the root area of the tooth. Again, this provides a very vital part of the tooth and provides a good functionality to the tooth as well. And crown portion of the tooth, we have two variations in that. We have a clinical crown, which is actually a little different than what you would see as an anatomic crown, and is another way to express that. Anatomic crown is where actually the crown meets the root, as in where the enamel meets the cementum at the CEJ. But your clinical crown is what you see within the mouth. So there are times where you have gingiva which is covering the tooth, and there are times where there is bone loss and it will go below, and this is the clinical crown is what you see in the mouth itself. Then coming to the root, we have clinical root and anatomical root. Again, it's very similar to the crown portion, but it's exactly, the clinical root is the portion of the root what you could see, and anatomic root is the portion which lies below the enamel, which is covered by the cementum. And technically these are all common terminologies which you come across in the literature and as we speak about it. And the apex portion of the tooth is where you have access of all the vital tissues entering the tooth, whereas we like blood vessels, nerve endings, and connective tissue which enter the tooth of the tooth. And the portion of the tooth where the crown meets the root is called the cervix or the neck of the tooth. And these are all again some of the highlighted terminologies commonly used in identifying tooth structures, different areas of the tooth structures. So again, looking into alveolar process, this is an extension of your maxilla and your mandible which support the tooth. As I was previously mentioning to you, the teeth are all suspended within the bone with the help of a periodontal ligament, which is a specialized connective tissue, and then alveolar process is the extension of it where it's harbored. So each of the alveolar process, we have an alveolar bone, which is a part of the alveolar process, which is the part of which lines the bone sockets, into which the teeth are embedded in them actually, and that part is called the alveolar bone itself. And a little more emphasis on periodontal ligament. Again, specialized dense connective tissue, and they're all organized by specialized fibers and groups which are oriented in a specific way, and each of these fibers have a specific functionality to it, but overall they help teeth to withstand all the masticatory forces of chewing, and provide maintain good health and sealing the tooth as well. So gingiva, coming to the soft portion of the tooth, this is a mucous membrane tissue that immediately surrounds the tooth structure. And again, gingiva has two different histologic presentation of it. The attached gingiva is the portion of the gingiva which extends from the gingival margin to the alveolar mucosa, but your free gingiva is the part of the gingiva that surrounds the tooth itself, and it's directly attached to the tooth surface, and these are all provides functionality and protection to the tooth itself, and aid in mastication. And I do have I'm going to briefly put other slides here. The idea behind this is to get familiar with common terminologies which are present in the intraoral cavity, oral cavity, like which is going to be used across in all the presentations when they are referring to the dental abscess case. And I would encourage to give a good read to get familiar with all these terminologies in these few slides. So before I proceed into talking about a radiographic anatomic landmarks, it's very important to understand why radiology is important and why we segue radiology into this case. Basically, radiographic diagnosis in the intraoral cavity has been a very successful implication of use of radiographs in helping you to diagnose any condition in the mouth, because with radiology you have many tooth structures in the mouth which show different densities of radiographs. So it's good to isolate your normal anatomic areas from the pathology to understand these areas. So in this presentation I'm going to talk to you a little bit about some common anatomic landmarks. In the meanwhile, there are some slides which also represent dental caries, dental restorations. All of these, how they appear on the radiograph, is what the main idea of this presentation. So the by far the most important and the most diagnostic value of a radiograph is to determine the amount of bone which is present or absent, and to find out all the local factors. There are so many other local factors which can be identified with this, as much as a calculus, which is a part of a disease process of a periodontal disease, restorations, or in common terms your fillings, and other pathologies which can lead to either bone loss in that area or bone formation, and these can be identified with the help of radiographs, and these are the areas which you cannot see clinically. And other than that, it has other diagnostic values, and just some of them are like as simple as dental caries identification, your periodontal conditions, and of course leading into all your periapical areas, the pathology around the tooth, and in the bone identification. So coming into radiology, I mean, there are different ways to do a radiograph, and of which the most important radiographs which you would see in the dental use are your bite wings, which is a different way to expose the radiograph. You have periapical radiograph, you have occlusal radiographs, and a few other radiographs which are limited to that. But again, your diagnostic skills should not be limited to just a confined area when you feel like your disease process is spreading beyond your confined area of the radiograph, because the radiograph has its own limitations as to what can be covered in the area you are going to see. So in those cases, you move from a intraoral radiograph to larger radiographs where you can identify the pathology or the condition what you're looking for, and it will be more diagnostic in value. So making a right choice of use of radiographs are very important. But the main idea behind this is to kind of identify some of the key anatomic landmarks and how they can be isolated from the pathology itself. So coming to the limitations of the radiograph, again I would like to emphasize this: a radiograph is just as a diagnostic tool, and it does not determine your success of your management, but although it will aid in your management, it would not say, looking at the radiograph you can't assess that. So that's when you have to clinically correlate your findings and your clinical findings to pair it with your radiographic interpretations. And the one thing radiograph does not isolate is your indication or your relationship of your hard and soft tissue, because soft tissue cannot be isolated well on a radiograph. Most of the time they appear as shadows. So when you talk about radiology, we are talking about two important things. One is radio opacity, which is radio opaque. You will hear it over and over from the rest of the few slides which I'm going to present. So what is radio opacity? So I wouldn't go into detail about how the radiographs work, but in general, radio opacity is the area which appears lighter in the film. So if you're looking at your brief radiographic, how the radiograph works, you basically you're exposed to radiation, X-rays, and some of the structures which are dense absorb that. And that means when your film captures it, it won't be capturing as much as, that many photons does not reach the radiograph, and that's how it appears radio opaque. On the contrary, you have a radiolucency, which refers to the darker areas of the film. In these areas, these are less dense areas where there is poor absorptions of the photons, and that means there is more photons reaching the film itself, and these appear as lighter areas, and this is kind of where you would see. So if you look at intraoral radiograph, you would see an array of shades within that, and it's good to kind of identify some of the at least landmarks of your radiographs to identify some of the key anatomic structures. So again, everything looks a lot different here. Enamel, cementum, dentine, bone, muscle, fat, air spaces, they all appear a lot different in that. Again, it based on your radio opacity and lucency. That means it depends on the bone density, and every structure is different. Or if you're looking into a restorative material, the nature of the restorative material, there are more restorative materials which are radio opaque, and there are some radiolucent materials, restorative materials which are radiolucent, and then there are crowns and other areas of the mouth which appear a lot more radio opaque because of the metallic nature of that restorations. So looking at the tooth structure itself, as we all know, enamel being the hardest structure, which is more of your inorganic content, which is directly related to them being a radio opaque material. Dentin and cementum are radio opaque, but you would see that even with comparing enamel to dentin, I have a slide next to it, next one, where I'll actually show the difference in that. But these are all few things where you have the pulp. Again, it's just connective tissue, blood vessels, and nerve endings, so you don't have much of radio opacity in them. They appear radiolucent. The lamina dura is the portion of the tooth where the tooth is suspended with, and that's a radio opaque, and that's a part of the alveolar bone. And then your periodontal ligament space, again, which is a soft tissue, which is again, they appear as a radiolucent material. And again, your alveolar bone is a radio opaque material. So this is a slide showing different opacities and radiolucencies. And as you look at each of them, you would see and you would appreciate each of those opacities in them. Along with this, in this slide, you would see some areas right near which are appearing as a restorative material in there, and there is also appearance of caries in there. But looking at the highlighted areas, enamel obviously being more radio opaque than dentin and cementum, where you can appreciate that. If you look at the pulp space, which is radiolucent, and alveolar bone, which is again a dense area. So that's kind of how you would identify each structure. So along with this, sometimes it's very common to get your normal anatomic landmarks mixed to a pathologic condition. So this is a radiograph of your lower molar area, and you would see some areas of normal anatomic structure, like a mental foramen, which is an opening, again is a radiolucent area, and you have areas where you have a submandibular fossa or a myloid ridge. They're all kind of important structures which usually overlap your normal in the area of a specific area of your radiation, and that's what you would see in those areas. So that we identify each of those structures, and I'm going to go over a few slides which is going to bring out some important landmarks in each of these areas. This is an example of a molar region. In your molar region, you have a mandibular canal which appears radiolucent, your external oblique ridge, which is radio-opaque, your myloid ridge, which is radio-opaque, and your fossas. All your fossas are going to be radiolucent. In this case, you will have a submandibular fossa, and your lower border of the mandible again is radio-opaque. So you have multiple areas like this. This slide shows an important structure of a radiograph from a lower mandibular area on the posterior, which is a very common finding, that you would see a mandibular canal as a radiolucency which goes like that along the direction of the mandibular nerve, where the canal harbors the mandibular nerve and which appears as a radiolucency. Looking at most of the common diagnostic radiographs, what we usually do, the one radiographs in the middle row are called the bite wings, and the one on the top are your periapical radiographs. There are different ways to take a radiograph, and these are all kind of representation of how these radiographs appear in different areas of the mouth. And this is again a comparison of your tooth microanatomy in line with your radiographic finding, and you would appreciate the findings at this slide with enamel and other tooth and surrounding structures, as you see. And I have a few more slides here which are representing different areas of your mouth based on where the radiographs are done, and all of these areas compared to the maxilla and mandible. I have these for you for your references as you read the literature, or if you come across a finding in a specific area, which I'm going to bring out. And I want to bring out the first radiograph here in the maxillary area, where we are looking at an anterior nasal spine in this area, which appears as a radio-opaque area. So that's kind of a common finding in the anterior maxillary radiographs. And the other most important thing what you would do in the anterior area of a radiograph is you would see your incisor fossa or a foramen, which is one of the commonest findings. Some of the times with this incisal fossa or foramen appears to be a lesion. So that's very important that you identify that structure and isolate that. Then your nasal septum again appears as a radio-opaque area. Then we have your palatine suture, which runs along there. Again, suture, the palatine suture would be a radiolucent area in between the dense maxilla that you would see. A couple of findings you would see in the upper anterior teeth radiographs are, you're looking at inferior concha. Again, they appear as a radio-opaque finding in your radiograph. And again, this slide I would like to spend some time to kind of present to you, because this is one of the commonest areas, which is the nasal fossa, which is kind of misinterpreted to other pathologies, because as you would learn the process of what happens in a sequela of a pathology coming from the odontogenic or a non-odontogenic origin, most of your pathologies which are radiolucent can kind of mimic a pathology around the roots of those teeth there. So this is one of the commonest findings, that your normal anatomic landmark would be confused for a pathology. So how do we isolate that? Again, like I said, radiographs are just a diagnostic tool, and you should correlate your clinical findings. So just for an instance, before I go into details of that, if you look at the apices of the roots of the maxillary central incisors, we talked about lamina dura, which is the lining of the alveolar bone towards the tooth, which suspends the periodontal ligament, which is a very dense opaque area. Usually, if there is a pathology coming from the tooth, there would be a break in the lamina dura, is one of the key isolating areas. And in this case, you wouldn't see that, and this is a normal anatomic finding. And there is no obvious clinical findings in the tooth, radiographic findings. So that's why it's very important to not interpret your diagnosis just by looking at the radiograph, but to aid your diagnosis is the main idea. So looking at your nasopalatine canal, again, your nasopalatine canal is also a radiolucent area which appears right in that area there. And depending on the angulation, sometimes you see more of these anatomic landmarks and sometimes you don't see them. So it's good that you kind of know what anatomic landmarks are present in what particular area. In the anterior maxilla, you also see nasal septum, you see nasal passage, and anterior nasal spine and premaxillary sutures. Again, based on the radiolucency and opacity, each of these structures appear differently. Your incisor fossa, again, looks as a radiolucency. And if you look at, again, the lamina dura in each of these cases, they are all very intact, kind of suggestive that it's just the overlap of your anatomic features. Because one thing what I would like to emphasize in radiograph is all these radiographs are two-dimensional images. So if you need more diagnostic imaging values in a specific area, you would want to move into more of a three-dimensional imaging techniques, let it be an MRI, cone beam, or other imaging techniques that you would enhance those areas. Cone beam, CT, other diagnostic aids which can be used in these areas. So if you're looking into further out, you would also see sometimes, I put this slide up because you can also see some of the soft tissue shadowing. If you look at that, the area which is highlighted for soft tissue, this is the overlap of the lip that you can also see, which is common to see in this area. So moving into a little more posterior to the central, so the central and lateral incisors of the maxillary, you would see a little more of the different part of the anatomy. You would also see the anterior wall of the maxillary sinus and the lateral wall of your nasal fossa. So depending on the area we observe. And the other thing I wanted to bring across is this was a good slide to point out some of the caries. If you look at the canine teeth, which is your teeth to the far left, and you can see a portion of the lateral incisor which have caries in them, where caries, again, I'm going to talk about a little bit about the caries at the end of my slides, but it's basically you would see a demineralization process in this enamel and dentin in those areas. And especially with the canine, you see the demineralization which is extending into the dentin, and you would also see some of the periapical areas of this tooth which is starting to get involved with a pathology there. As you could see, there is a small break in the lamina dura of the tooth of the canine. Again, this is a very tricky slide I wanted to bring across because sometimes you would see a maxillary sinus which is kind of mistook for a periapical lesion or a periapical pathology. In this case, you see a tooth, and the tooth you're looking at had a root canal in them, and that's what it is. That is the appearance of how a root canal would look. But the lamina dura is intact, and this being a two-dimensional image, you would see an overlap of the sinus in that area, giving an appearance of a lesion there. And again, these are some of the other common radiolucencies and opacities you would see in these areas. And talking about the premolar maxillary area, this is very important slide that I want to emphasize on. If you look at that, this is where this kind of a radiograph would bring out most of your sinuses which can be seen. And this is a representation of sinus spaces. But again, all of these areas you would see that the lamina dura is intact and the maxillary sinus is overlapping the roots of the teeth. And this is again a very important landmark of this pathology, of this anatomy, sorry. And again, looking into maxillary areas as you go distal to the premolar area, these are some other important landmarks that you could see. And most of the time, depending on the type of radiograph you expose, it could be a smaller radiograph, or if you want to see something distal to the zygomatic bone, then you have to be taking a different type of radiograph, which may not be an intraoral radiograph, and that's when it becomes an extraoral radiograph. But you would normally see some overlap of these structures when you're looking at an intraoral radiograph. And these are all some normal anatomic features which you can see in the radiographs as well. So as we go into the third molar area, again, sometimes you would see a lot more structures beyond your normal findings. And you can see areas like your tuberosity, your zygomatic process, and then and these are the structures which can usually come across in these findings. Sometimes you would also see a pterygoid hamulus if the radiographic film is placed all the way back there. And it's easy to trap some air spaces which we can be seen on these radiographs also, capture some air spaces. Yes, looking into mandible, again, similar, maxilla has a lot more structures which overlap usually, but even in the mandible you have certain areas of the normal anatomic landmark which overlap your teeth, which is good to know. Again, all your foramens are radiolucent. I want to specifically bring out your mental foramen because you would see this over and over again in dental radiographic findings that they appear as a pathology. In this case, your mental foramen is placed between your premolars, and depending on the angulation of the radiographs, sometimes this mental foramen lies right below the root of a premolar, which gives an appearance of a pathology. And this is an example of that, where you see two things. One is your mental foramen, which is between your premolars, but at the same time there's a pathology on the root of the premolar, which may be close to a periapical granuloma or abscess or a cyst, where you could see as there's a break in the lamina dura. And this is some of the common findings which can be overlapped between each other. Dental caries. I want to segue into dental caries. The reason is to understand the basic snippets of dental caries in a nutshell. key important things about dental caries, it's being a multifactorial oral disease, and it's a complex interaction of the oral flora with the interaction of a fermentable dietary carbohydrate on tooth structure, and it starts off as a breakdown of your mineralized structure, and once it goes into your connective tissue, then it leads to other odontogenic infections as it proceeds to that. And I just wanted to bring in a sequelae and a basic understanding of dental caries and how it gets to the periapical area. Like I said, very important that it's a multifactorial condition. So it's just not one specific thing does not cause caries. It's a very dynamic process, and a lot of it depends on a balance, what causes caries, and once the caries starts, and it progresses in a different way. So this is kind of a overlap of how your caries happens. But your initial process of caries, right, you're looking at a histosection of a tooth. At the enamel, the first thing you form is a pellicle formation on the tooth, and this pellicle easily colonizes as it harbors microorganisms, and specifically the streptococci are the ones which are the early colonizers in this area, which are gram-positive cocci, and this interact with the sugar and they break down sugar to create an acidic environment. So once you have an acidic environment, this starts to leach away the enamel. It takes away the enamel, and once you have an enamel taken out, once the caries goes into the dentin, the caries would spread a lot faster because it's a less mineral content, and that's where it segues into the pulp. But again, this is kind of a snippet of that. Multiple forms of caries. Radiographically, they appear as radiolucent areas. To the slide on the far right would show a premolar on the maxillary premolar showing caries under the restorations. Those dark light areas, the lightened areas are your restorations and crowns. But if you see radiolucency, you're seeing radiolucency around those areas. But as I was explaining to you, the most resistance you would get from your teeth is your enamel, because that's when you have a process of most resistance. But it's mainly a demineralization process. But once it gets into dentin, it goes a lot faster. And then once it's reached the pulp, it's more of an inflammatory response going into bone destruction in the periapical area, and all of these boning, and you have bacteria which leave toxins which lead to further breakdown of your inflammatory process. So in general, this is what I kind of wanted to give a small example of what happens. So it starts off as a demineralization process, but then it's picked up by your other tissue responses, toxins, and then further breakdown, and then your inflammatory process kicks into those areas. And again, when you have a periapical involvement, you would see a couple of things like widening of the periodontal ligament space, and your periapical radiolucency may be present based on the amount of breakdown of bone which is present around that root apices. Thank you.